Welcome back. In our previous sketch at the Gorgon Cave, you learned all about the clinical features of cirrhosis. Now it's time to do something about it. Oh, yeah, we're still in Greece. But instead of living the myth, we're gonna recreate the myth from the safety of the workshop. That stony liver, remember, represents hepatic cirrhosis due to chronic liver cell injury. In this sketch, we're going to assess the severity of cirrhosis and look at some complications and management options. Before we begin, let's recap the clinical presentation of cirrhosis with our sample assessment from part 1. Bellerophon is a 55-year-old male presenting with poor appetite and nausea for the past month. He also complains of a swollen belly and puffy feet that have been bothering him for several months. On questioning, he admits to drinking a 6-pack of beer almost every night for the past 20 years. Physical exam is significant for bilateral gynecomastia, spider angiomas on the chest, visibly dilated periumbilical veins, and a palpable spleen tip. Labs are significant for an AST of 195, ALT of 101, elevated GGT, and a platelet count of 80. Given his history and significant alcohol use, his symptoms and signs are concerning for cirrhosis secondary to alcoholic liver disease. On with the plan. The first step is to assess the severity of liver disease. One way we do this is by calculating the patient's MELD sodium score. The MELD sodium score uses values for serum bilirubin, creatinine, sodium, and INR to predict 3-month survival in patients with cirrhosis. An increasing score is associated with increased mortality risk. To emphasize that this is a score measuring mortality risk, we've given this bronze melder a skull mask. And to remind you that it's 3-month survival specifically, we put 3 moons on the wall above. It's primarily used to prioritize patients on the waitlist for deceased donor liver transplantation. In 2016, serum sodium was added to the MELD score. Hyponatremia can occur in the setting of cirrhosis and is an independent predictor of mortality. Hyponatremia is related to increased water retention in the setting of increased ADH secretion. Check out our last video for the full mechanism underlying the hyponatremia seen in cirrhosis. There are a few conditions associated with chronic liver disease not accounted for in the MELD score that may affect survival. These are known as standard MELD exceptions. Patients who meet criteria for one of the standard MELD exceptions may be eligible for an upgrade in their MELD score. The exceptions include hepatocellular carcinoma, hepatopulmonary syndrome, portopulmonary hypertension, and a few other conditions. The MELD score will come up again at the end of this video when we discuss indications for liver transplantation. Another method we use to assess liver disease severity is the Child-Pugh classification system, which uses values for serum albumin, bilirubin, and prothrombin time, as well as the presence of ascites or hepatic encephalopathy to stratify patients into 3 classes of cirrhosis. To remind you that the Child-Pugh classification system correlates with survival, we've incorporated our mortality skull symbol into that last sculpture there. Patients in Child-Pugh Class A have well-compensated cirrhosis. Those with Child-Pugh Class B cirrhosis have significant functional compromise, and those in Child-Pugh Class C have decompensated cirrhosis. 1-year survival rates for patients in Class A, B, and C are approximately 100, 80, and 45% respectively. Once you've assessed the severity of liver disease, it's time to treat the underlying cause. All patients with cirrhosis, especially those with alcoholic liver disease, should refrain from alcohol use, as highlighted by the falling drinking horn. We also included a falling viral lantern to remind you that patients with hepatitis B or C should receive antiviral treatment. Recall that non-alcoholic liver disease typically develops in patients with at least one component of the metabolic syndrome, such as hypertension, diabetes, hyperlipidemia, and obesity. Patients with NAFLD should be treated with lifestyle modification, diabetes control, and lipid control. Weight loss specifically has been shown to improve LFTs, liver histology, insulin levels, and quality of life. In addition to treating the underlying cause of liver disease, you should also take measures to prevent further insults to the liver. Vaccination against hepatitis A and B for those who are not already immune can help prevent further liver damage. Patients should also avoid medications, supplements, and other substances that are associated with liver injury. Because patients have impaired hepatic metabolism, certain medications should have their dose adjusted or be avoided entirely. All right, that about does it for the general management of cirrhosis. But what about the complications of cirrhosis? Despite all of these measures, patients with cirrhosis can indeed still develop complications, and it's crucial that you know how to identify and manage them. The first one we'll talk about is esophageal varices. As mentioned in the prior sketch, this is a consequence of portal hypertension and can lead to life-threatening bleeding, presenting with hematemesis and/or melena. Most patients with cirrhosis should undergo diagnostic upper endoscopy to screen for esophageal varices, determine the risk of variceal hemorrhage, and indicate strategies for primary prevention of variceal hemorrhage. Patients with medium or large varices are at risk of hemorrhage and should be given prophylaxis to decrease the risk of bleeding. Patients with small varices with high-risk features or later-stage disease may also get treated. Non-selective beta blockers such as propranolol and nadolol are used to decrease progression and reduce the risk of variceal hemorrhage. They're thought to act by decreasing adrenergic beta activation in mesenteric arterioles, which results in unopposed alpha-mediated vasoconstriction and decreased portal venous flow. Endoscopic variceal ligation is an alternate therapy for primary prophylaxis of variceal hemorrhage. It's performed on patients with medium or large varices who are intolerant of or have contraindications to beta blockers. And what about acute management of variceal hemorrhage? Check out our surgery course for a full discussion. Next, let's talk about ascites, which occurs in patients with portal hypertension. However, cirrhosis is not the only cause of ascites. And that's why we have a dedicated ascites DDX video coming up next. Recall from our last video that ascites results from portal hypertension as well as decreased oncotic pressure from impaired albumin synthesis. It presents with abdominal distension, shifting dullness to percussion, and a positive fluid wave. Patients suspected of having ascites based on history and physical examination should undergo abdominal ultrasound to confirm its presence. So we've brought in an ancient Greek ultrasound bullhorn. A paracentesis should be performed for newly diagnosed ascites, or for patients with pre-existing ascites who are hospitalized, or, thirdly, for patients with ascites whose condition is worsening. If cirrhosis is the cause, expect to see clear yellow fluid, unless there's an underlying infection, but more on that in a minute. Peritoneal fluid is then sent for analysis. The serum to ascites albumin gradient, or SAG, is the serum albumin concentration minus the peritoneal fluid albumin concentration, which is why the pot is a sanguinous red on one side and an acidic yellow on the other. Expect the SAG to be greater than or equal to 1.1 grams per deciliter, indicating the presence of portal hypertension. Also expect the total protein in the peritoneal fluid to be low. Don't worry, we have a bunch more info on peritoneal fluid analysis in our upcoming ascites DDX video. The treatment of ascites aims at decreasing fluid overload. It involves restriction of dietary sodium, which limits the kidney's ability to hold on to salt and water. Diuretics are also administered. Combination therapy with spironolactone and furosemide is the standard therapy for ascites. So on this leaky diuretic pot here, we've painted a spiral for spironolactone and a loop for the loop diuretic furosemide. For patients with tense ascites, more rapid removal of fluid can be performed without hemodynamic compromise with a large volume paracentesis of 4 to 5 liters. So we've added a tap on the side here to relieve the pressure. Let's move on to a potential complication of ascites. Yes, a complication of a complication. Spontaneous bacterial peritonitis, SBP, refers to bacterial infection of acidic fluid in the absence of an intra-abdominal, surgically treatable source. It generally occurs in patients with ascites secondary to cirrhosis. Bacterial translocation is the presumed mechanism for development of SBP, with gut flora traversing the intestine into mesenteric lymph nodes, leading to bacteremia and seeding of the acidic fluid. As a result, the most common organism is the gut bacterium E. coli. Klebsiella pneumoniae is another common pathogen. These two are depicted by Her. coli here and as Klebsiella club. Streptococcal species and other gram-positive cocci are other common pathogens associated with SBP, possibly due to the altered microbiome of patients with cirrhosis. SBP almost always develops in patients with large volume, clinically obvious ascites in the setting of advanced cirrhosis. Also, the higher the MELD score, the higher the risk of SBP. Now, it's extremely important to recognize spontaneous bacterial peritonitis early. These patients rapidly progress to shock, followed by multisystem organ failure. Subtle changes in mental status are one of the most common signs of SBP. and may only be noticeable by someone who knows the patient well, like a spouse. Patients may also present with frank delirium, confusion, and slowed cognition. Abdominal pain may also be present, but it's often less prominent due to the presence of ascites. The pain is usually diffuse and constant. Of note, this pain is different than the pain felt from the stretching of the abdomen in the setting of tense ascites. Diarrhea is also common in patients with SBP, likely due to an alteration in gut flora. Patients typically present with fever. It's important to appreciate that patients with advanced cirrhosis are usually mildly hypothermic. So, a temperature of 37.8 degrees Celsius, or 100 degrees Fahrenheit, or greater must be taken seriously. And that septic pot is there to remind you that patients may also present with hypothermia or hypotension. These are signs of advanced infection and indicate a poor likelihood of survival. On physical exam, patients can present with diffuse abdominal tenderness. These patients do not develop a rigid abdomen, although rebound tenderness may be present in advanced cases. On labs, objective signs of infection may be present, including leukocytosis and metabolic acidosis. At Sketchy, we always include a flock of white birds to represent elevated white blood cell count. For making the diagnosis of SBP, paracentesis is the test of choice, depicted by the sample of fluid leaking from the pot there. The main diagnostic criteria are a positive ascites fluid culture and a neutrophil count greater than 250 per microliter. These are depicted here by the culture dish on the floor, as well as the first responders carrying the stretcher. At Sketchy, we think of neutrophils as the first responders of the immune system. Paracentesis should be done before antibiotic therapy is initiated, by the way, as early antibiotics can cause a negative ascites culture. All right, before moving on, a quick aside. Spontaneous bacterial peritonitis must be distinguished from secondary bacterial peritonitis. Instead of being spontaneous, secondary bacterial peritonitis is, secondary to something. That something is a surgically treatable source of infection, such as a GI tract perforation or an intra-abdominal abscess. I know you're thinking, a perf? I know a surgical abdomen when I see one. The thing is, ascites separates the visceral and parietal peritoneal surfaces and prevents development of a rigid abdomen, even with organ perforation. Other signs that point toward a secondary cause of peritonitis include a polymicrobial culture on gram stain, which indicates a perforation, a poor response to antibiotics, especially if there's an increase in ascites PMN count on follow-up paracentesis, and there's also a few extra acidic fluid labs we can look at, listed in the text on the screen. If signs point toward a secondary cause of infection, get plain and upright abdominal films as well as a CT abdomen to look for that surgically correctable etiology. All right, how about a sample assessment statement just for good measure? Bellerophon is a 55-year-old male with a history of cirrhosis secondary to alcoholic liver disease, admitted to the emergency department for abdominal pain. He describes the pain as diffuse and constant, and his wife reports that he's more confused than usual. He takes no medications and drinks a 6-pack of beer daily. His temperature on admission was 101 degrees Fahrenheit, with the physical exam remarkable for yellow discoloration of sclera, distended, non-rigid, diffusely tender abdomen with shifting dullness and fluid wave present. Diagnostic paracentesis showed PMNs at 310 cells per milliliter with culture scent. Fever, abdominal pain, and ascites fluid analysis are concerning for spontaneous bacterial peritonitis. While awaiting the results of the fluid cultures, patients with suspected SBP should be started on empiric antibiotics. Empiric therapy usually includes a third-generation cephalosporin, such as cefotaxime or ceftriaxone, which is why Hercules is fighting a